Hey, I'm Burkhard Sievers, professor of medicine, specialized in cardiology and vascular medicine, and also in gender medicine, and a board member of the German Society of Gender-Specific Medicine. As you may have noticed, gender medicine is gaining more and more importance in Europe and across the countries. The country of origin, however, is the US, and there is the most experience in gender medicine and also in running gender programs. So I thought about launching an interview series to connect with peers, learn from them, and make this available to all of you. So let's get started. Today, I'm meeting with Dr. Noel BaireyMerz. She's a cardiologist and professor of cardiology at the Smidt Heart Institute, Cedars Senior Medical Center, Los Angeles, and director of the Barbara Streisand Women's Heart Center. She's one of a kind of an expert in preventive cardiovascular medicine and has done extensive research in this area. Hi, Noel. Great having you.
Hi. Lovely to be here with you.
Yeah, thanks so much. So let's learn a little bit about yourself and your Women's Heart program. So Noel, where is your strong interest for women's heart disease coming from?
I suspect it probably has something to do with being one of the few women in cardiology. That is certainly true in the US. I suspect that's probably true in Germany and throughout Europe. And I was always very interested in research. And so I started stratifying my data by gender, by sex, fairly early on, just because I was curious, and that sort of launched a whole career because there are important differences.
Yeah, and you did a tremendous work in your research, so I'm aware of this. And Noel, why is it so important to offer a women's heart program?
Well, you know, it turns out, and of course it depends on the heart condition or the health condition, but there are important sex and gender differences. Sometimes it's 5%, sometimes it's 20%. But I'm a cardiologist, and if you think about the hundreds of thousands of lives that are lost every year due to cardiovascular disease, you know, a 5, 10, 15% difference is a lot of people. And so we really felt like it was important that these be recognized, and increasingly when there is an important difference, that a different dose of drug, a different diagnostic test, a different approach would be better for women and men.
That is so true. And you have this Women's Heart program running. So what are the 3 most common symptoms, health problems or requests of your patients?
Well, as you know, being a cardiologist yourself, the most common complaint is chest pain, followed by shortness of breath, followed by palpitations. Yeah. And we think number 3 usually is not very serious, but we have to pay attention to it. Certainly chest pain or chest discomfort, certainly shortness of breath or just an inability to catch your breath. These are really critically important indications that can be due to the leading killer of women and men, cardiovascular disease. Pretty important to pay attention to them.
Yeah, that's so true. And do you have in your program, do you have a special workflow or standard workup you offer the patient that are coming to your clinic?
One of the nice things about gender medicine is it really is our best example right now of personalized medicine, meaning as soon as that patient walks through the door, you can be reasonably confident about their gender being male or female. And so we actually don't have standardized protocols for anything. We do offer specialty care for things that are more prevalent in women, such as ischemia with no obstructive coronary disease, or heart failure with preserved ejection fraction, or spontaneous coronary artery dissection. And we have standard approaches to those more specific problems, but each patient is an individual, be it a woman or a man, and we treat them as individuals.
Yeah, I think that is the best approach. Is it very busy in your clinic? How many female patients do you or your colleagues see during a day or on a monthly basis?
That's an important question. We have a faculty practice. So myself, I have 2 female cardiology colleagues, and then we have 2 nurse practitioners, as well as we have a large heart failure group, heart transplant group, a large EP group, electrophysiology. But anyway, each of us sees patients 1 to 2 days a week, and then the rest of the time is research and teaching. And I probably see maybe 100 to 120 patients a week.
Oh, wow, that's a lot. That's a lot.
Yes. Well, we function as a team.
Yeah, yeah. So all your colleagues are aware of these gender differences and take care of the women's heart disease, right?
We work together, and again, we dominantly try to see these specialty issues that community cardiologists and primary care physicians are either not as comfortable diagnosing and treating, or they've missed it. We have a self-referral option, meaning community patients can book and see a cardiologist without a primary care referral.
Oh, God, that's nice. That's nice. And how do you think is the awareness of gender medicine in general population in your city, like Los Angeles?
I think that it is increasing. Los Angeles is a very large city, as we all know. I would say that the average person walking down the street is probably not that aware. But we certainly are busy, and I just want to characterize that 100 to 120 is per month. If I said per week, that is a mistake. And so, you know, we are increasing our volume. We have added cardiologists. So I'm pleasantly surprised to think that this idea and this concept of getting specialty care and precision medicine is taking hold.
All right, all right. So last question is, what are the most surprising or exciting recent research findings for you regarding gender medicine? I'm sure you have a lot to tell now.
We're very excited about our ischemia with no obstructive coronary disease. This is the term now, INOCA. And we are showing that they are at intermediate, have heart attacks, typically small heart attacks, and that this appears to be progressive to heart failure with preserved ejection fraction. And we are developing new treatment targets regarding that pathophysiology. So we're actually pretty excited about being able to make a difference for this predominantly female conditions. We're also very excited. We're halfway through a randomized controlled trial called Warrior for those patients. And we are halfway. We were slowed down by the pandemic in terms of enrollment, but we will finish. And this will be what we call a guidelines informing trial, meaning it will help all the physicians of the world know how to treat these female patients, because it will go into guidelines, and physicians that follow guidelines have very high quality care.
Yeah, that's very great. So yeah, that's a great study and great work. So Noel, thank you so much for giving us a generous insight of what you're doing and what your program does. And it was a pleasure meeting you. I hope we stay in touch.
I hope our paths continue to cross. Thank you for your leadership as well.
Thanks a lot. Bye-bye.
Bye-bye.